Hello everyone, I am Sulu Fan from the First Clinical College of China Medical University. Today we are going to learn hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy can be replaced with HCM for short. As a kind of cardiomyopathy, hypertrophic cardiomyopathy is a disease regarding the myocardium with the characteristics of a marked left ventricular hypertrophy. This kind of hypertrophy is usually asymmetric. Because hypertension, infiltrative and metabolic diseases, and valvular heart disease, such as aortic stenosis, can also cause left ventricular hypertrophy. Hypertrophic cardiomyopathy should be defined in the absence of these causes. It is a leading cause of sudden death in the young people and is an important cause of heart failure. According to the anatomy, hypertrophic cardiomyopathy can be classified into several types. Look at these figures. Hypertrophy of the septal area is the most common type, consisting of about 90% of the cases. Another type is manifest as the hypertrophy of the apical area. These two types are both asymmetric. In only a few cases, the hypertrophy is symmetric with marked ventricular thickening. If the hypertrophy causes obstruction of the outflow tract of the left ventricle, we call it hypertrophic obstructive cardiomyopathy, or HOCM. Similarly, the others are classified as non-obstructive hypertrophic cardiomyopathy. The etiology of HCM is attributed as gene mutation. It is proved to be autosomal dominant pattern of inheritance. Family history is an important clue for detecting a patient with HCM. However, related individuals who carry the same mutation may have a different extent and pattern of hypertrophy. Hypertrophic cardiomyopathy is characterized by misalignment and misarray of the enlarged myofibrils and myocytes, which can also occur to a lesser distance in other cardiac diseases. The myocyte nuclei vary markedly in size. Although hypertrophy is the defining feature of hypertrophic cardiomyopathy, interstitial fibrosis and microvascular disease are also present. Here are some possible symptoms of HCM. Impaired diastolic function of hypertrophic heart induces pulmonary congestion. As a result, dyspnea on exertion is the most common presenting symptom. Increased thickness and decreased luminal area of the intramural vessels in hypertrophied myocardium contribute to microvascular ischemia and angina. Therefore, chest pain with either an atypical or typical exertional pattern will be the chief complaint. Due to low cardiac output and some arrhythmias, such as atrial fibrillation or ventricular arrhythmias, palpitation, presyncope or syncope episodes will be the symptoms of some patients, and sudden death may occur if there is ventricular tachycardia or fibrillation. During the physical examinations, the heart border may be normal or slightly enlarged. Due to the decreased ventricular compliance, the forced heart sound is a common sign in auscultation. For the hypertrophic obstructive cardiomyopathy, systolic obstruction is initiated by drag forces. The forces push an anterior displacement of the anterior mitral leaflet into contact with the hypertrophied ventricular septum. That is why we will hear systolic heart murmur best at the 3rd to 4th intercostal space by the sternal left border. From the outflow tract turbulence during ventricular ejection. The murmur can be enhanced by bedside maneuvers that diminish ventricular volume and transiently worsen obstruction, such as standing from a squatting position or the Valsalva maneuver. Usually, 3 will be detected simultaneously. In addition, the systolic anterior motion of the mitral leaflet will lead to mitral regurgitation, and the systolic murmur will be detected around the apex area. Some laboratory examinations could be used to differentiate and evaluate HCM. Chest X-ray and electrocardiography are actually not very specific. Normal or slightly enlarged silhouette of the heart may be the only finding in X-ray. ECG may be various with possible presence of left ventricular hypertrophy, inverse T wave, or Q wave. This should be differentiated from myocardial infarction. Echocardiography is a simple method for identification of HCM with specific findings. The typical manifestations include asymmetric hypertrophy of the left ventricle without enlargement of ventricular chamber. Usually, the thickness of septum is over 15 mm, or the thickness ratio of septum to the posterior wall is over 1.3 at diastolic phase. Some phenomenon, also called systolic anterior motion of the mitral valve, is a classic finding of obstructive HCM. Cardiac catheterization and left ventricular angiography sometimes are used to quantify the pressure gradient of the left ventricular outflow tract and to make clear the shape disorder of the left ventricle. Endomyocardial biopsy may be helpful if pathological examination supports the characteristics of HCM. However, these examinations are all invasive. Recently, they are not commonly used as some advanced measures come out. Cardiac MRI are good for detecting changes of myocardium, heart structure, and cardiac function. Findings of specific gene mutations are no doubt convincing proofs of HCM. Although the symptoms and the signs may be similar to some diseases, such as acute myocardial infarction or other cardiomyopathies, the specific hypertrophic change on echocardiography is helpful for diagnosis. If there is family history or defined HCM or undefined sudden death, it will increase the accuracy of the diagnosis of HCM. Because HCM is idiopathic, treatments are mainly associated with improving the hemodynamics, the symptoms of heart failure, and arrhythmias. Beta blockers and non-dihydropyridine calcium antagonists are generally used to improve diastolic function of the left ventricle, to reduce the obstruction of outflow tract, to reduce heart rate of atrial fibrillation, and to relieve myocardial ischemia. Beta blockers can also decrease the possibility of fatal ventricular arrhythmias. If the patient presents heart failure, medications such as vasodilators and diuretics should be used with caution to avoid hypotension and hypovolemia, especially in obstructive HCM. As these medicines will induce an elevation of the pressure gradient of the left ventricular outflow. Cardiac glycosides should be avoided, as they may increase contractility and worsen diastolic dysfunction and obstruction. If there is atrial fibrillation, amiodarone is the preferred antiarrhythmic agent, with radiofrequency ablation considered for medically refractory cases. Anticoagulation to prevent embolic stroke is also recommended. For those with outflow obstruction, some non-medical therapies, for example, surgery of partial excision of septum or septum ablation with echo, may be effective. Finally, the device ICD, namely implantable cardioverter defibrillator, is needed for patients with high risk of sudden death. That is all for this class. See you next time.